to the 11th session of Eco Made Easy. This is the 11th session, and thank you all for always making it successful. And today we have with us Dr. Manish Bansal. We all know he's the president of the Delhi NCR branch of IAE, as well as he's the vice president of the national body, that is the Indian Academy of Echocardiography. He's here for the expert comments. And thank you all the faculty for always being there. Today, before moving forward, let me just tell all the participants, I'll keep reminding all of you, keep registering for the Eco Asia. I hope you are getting the flyers and all the information about the Eco Asia in various groups. So keep, planning about it and participate, submit your cases, interesting cases, and submit good abstracts, tell your people around, and let's participate in a bigger way. All right. So today's talk is a little different one. And today, Patna is, taking care of the entire session. Both the speakers are from Patna, and both of them, I'm sure, are going to do a great job. So today it is a little, we are not going to teach echocardiography today about the mitral valve, how to assess the mitral valve disease. That has already been discussed. Today we'll be bridging the echo findings with the clinical judgment. What should be the interpretation of our echo? It is not just recording values. It is just how to interpret and how to improve the clinical judgment. So over to you, Dr. Shraddha Ranjan, for your presentation.
Thank you, ma'am. Is my screen visible?
No, it's something else is coming. Your
Okay.
talk is
just
not.
a second.
Yeah.
Just looking.
It was showing up earlier. Suddenly Zoom has.
Yes, ma'am. Yes.
Yeah, now it's here. Now it's here.
Good evening, everyone. Thank you for joining. And I'd like to thank Dr. Rakesh Gupta sir and Dr. Hansa ma'am for giving me this opportunity. And my regards to Dr. Manish Bansal sir for taking out his precious time and accepting to moderate this session. So my topic today is mitral valve disease, when to intervene. So I'll start with the concept that echo should answer a clinical question and a surgical decision, not just generate numbers and report. Why so? Because when we say that when we are doing an echocardiography, we are with a patient, we should just not focus on whether the mitral regurgitation is mild, moderate, severe. We should try to give all the information which will be helpful for the clinician to make an informed decision whether this patient should be kept on medical management, how long the follow-up should be, when he should be called for the next echocardiography, whether he needs some intervention, whether that intervention is going to be percutaneous or surgical. So this all information is actually gathered from the echo report. And the report should be perfect enough to help the clinician, the referring physician, or the cardiologist, and the patient as well in the process. So for that we have to have a knowledge of echocardiography, as well as we have to be very thorough with the guidelines for the management of valvular heart disease. In this case, we'll be discussing mitral disease only. So I'll be referring to the 2025 ESC guidelines, and we'll be going through the guidelines, reviewing the management protocols, along with the cases, to trying to put together everything in a practical scenario, which we see every day. Mitral valve is something which we come across every day in our labs, many patients sometimes a day. So that's how I'm going to approach the talk today. So echo, so first, as I said, that it will confirm lesion severity. Definitely, if we are dealing with mitral valve, we have to confirm whether the lesion is mild, moderate, severe. Are there any associated lesions? Is there a thrombus? Is there a vegetation? That will be the next step. Then we have to also assess other parameters of hemodynamic impact, like chamber size, ventricular function, and pulmonary pressures. So this part has become increasingly is now very has taken up, coming into importance nowadays, because there is a shift towards early intervention. Before, as we have seen that before, the intervention guidelines was that if the patient is symptomatic, then only the trend was to intervene. But now these guidelines have also shown a shift, like we have seen in aortic stenosis, that early intervention actually prevents the irreversible damage the heart is going through because of that particular lesion. But for that also, there has to be some, we cannot intervene in each and every asymptomatic patients. There has to be some parameters of which show that there is a hemodynamic impact, like the LV dilatation, LV ejection fraction, LA dilatation now also has shown that the patient should be intervened early, because these patients do not fare well if the LA gets dilated and atrial fibrillation is there. So these parameters have to be reported in the echo report as well. And if we have the knowledge that what parameters guidelines are referring to, then only will be able to give a proper report. And at the end of the day, it has to be correlated with symptoms and the guidelines have to be applied. So that is how a patient, when we come across in a lab, we have to approach. So decision to intervene is not only guided by echo, definitely, but it is where we start. So if a patient comes to a doctor, first is clinical examination, which is actually very important. The history, as I said, symptoms, asymptomatic, that clarity has to be taken, has to be there. But sometimes it is not very very informative. History can be misguiding, or because the patients they have decreased their effort tolerance, they do not work that much, and but say that okay, we are feeling okay. So clinical examination has its limitations, definitely. So second step is confirmation of disease severity, where the role of echo comes, what we'll be talking about today. Once we have confirmed the disease severity, then concomitant cardiac conditions, whether the patient has coronary artery disease or some other valve is involved, or some other second disease is there. Then with what are the comorbidities we are dealing with, how frail is the patient, then a heart team evaluation, which stratifies the risk, whether that patient is suitable for surgery, whether that patient needs to go some percutaneous treatment or to be left alone on medical management. That is also a shared treatment decision between the patient and the doctor. But before all this, what comes again and again? Confirmation of disease severity by echocardiography. So coming on to mitral valve apparatus. So as the word says, mitral valve is just not a valve which has two leaflets, anterior, posterior, what we call. It is actually apparatus. It is a system of five components. It starts with leaflets. There is an annulus where the leaflets are anchored between the left atrium and the left ventricle. There is an annulus. Then comes the anterior leaflet and posterior leaflet. Then the chordae, with which the leaflets are attached to the papillary muscles. Then the papillary muscles, and then papillary muscles are attached to the certain part of left ventricle. So all these five components are there in the mitral valve, and the functioning depends on each and every as component of mitral valve apparatus. If there is a defect anywhere in this, there will be some sort of distortion in the mitral valve functioning, and it may cause incompetence or stenosis. So with this basic idea, we'll move forward. Mitral stenosis. So we're not going to into the details of mitral stenosis assessment. We'll just start that we have got a patient with rheumatic mitral stenosis, which is the most common scenario, which and has a severe. Severe means mitral valve area is less than 1.5 centimeters square. If the patient is symptomatic, and we know that the mitral valve area, we have decided that mitral valve area is less than 1.5 by planimetry. There is nothing to be checked now. If the patient is symptomatic, yes, he needs some intervention. If the valve is suitable for PMC, PMC is percutaneous mitral commissurotomy, which we commonly refer to as BMV. So if the patient is suitable for BMV, then it's a class 1 indication to undergo BMV. If the valve is not suitable or there is some contraindication for BMV, then the patient needs to go for surgery. So that part is quite clear. If the patient is symptomatic, everything intervention has to be there. If the patient is asymptomatic, then it becomes little tricky. Then we have to look at the finer details. We have to look if is there a high risk of embolism or a high risk of hemodynamic decompensation. High risk of embolism means if the patient has previously suffered a stroke or a acute limb ischemia, means there was a embolic event from the mitral stenosis, or patient had a paroxysmal atrial fibrillation, or we see a very dense sec. That is also new in the guidelines. If there is a dense sec there, what is spontaneous echo contrast, then also this patient needs to we need to intervene in this patient. If there is no contraindication to PMC, he will go for a BMV. If there is any contraindication or the valve is not suitable, then for surgery. Suppose we do not find any of these factors, there is no high risk of embolism, the LA is not very big, there is no clot, no history of a stroke. Then also the patient is asymptomatic, claims to be asymptomatic, and we are finding a severe mitral stenosis. We need to put him through an exercise testing, which is a stress echo. And if the patient develops symptoms, again, he's eligible for intervention if he develops symptoms and if the exercise capacity we find on the treadmill is not so good. If not, and he is able to run quite nice, he more than 10 minutes, then obviously that patient we can keep on follow up. And when we do a stress echo, so why, when we need exercise testing in mitral stenosis, either the patient claims that he's asymptomatic and we are getting a severe mitral stenosis, or sometimes the reverse can happen that the mitral stenosis is non-severe, but the patient is symptomatic and he's taking some medication for bronchial asthma, or sometimes we come across this scenario that the dyspnea is not explained and we are not getting gradients, and window is not so good, and mitral valve planimetry cannot be done, and it is like moderate MS. The patient is diagnosis is moderate MS. In these patients, also exercise testing can help, because then the guidelines say that on exercise, if the mean gradient increases to 15 mmHg and the pulmonary artery systolic pressures increase to more than 60 mmHg, and even on DSE, if the patient is not able to walk, we do a dobutamine stress echo and the mean gradient increases to more than 18 mmHg. These patients also warrants either intervention or a close follow-up, because this can be kind of latent severe obstruction of the mitral valve, which actually increases with the stress dramatically, and these get symptomatic. So that is exercise testing, which was in the guidelines. So on exercise, if the patient is symptomatic or there is an increase in the gradient and pulmonary artery systolic pressures, these patients should also undergo intervention. This is a paper from which these guidelines has been probably taken, and they show an example that at the rest, the mitral valve mean gradient is 11 mmHg, pulmonary artery pressures are 34 mmHg, and after stress, mean gradient increases to 31, and pulmonary artery pressures increases to 60. So these are the patients. This is how we can evaluate such patients. Now, the other aspect, that suitability for PMC or BMV, which we were talking about, which are the valves which are suitable. So the basic idea, theoretical idea, there are many scores and everything, but basic idea is that the valve is not very calcified, if the subvalvular apparatus is not very bad, the disease is not very advanced, then they are more suitable for percutaneous treatment, because that is there is a we must all be knowing that a balloon goes to the mitral valve and expands the valve, and if there is a commissural, the commissures are broken there, and that causes the mitral valve orifice to increase. So that can happen only when the valve is pliable, it's not very calcified. So that is the practical knowledge we all have. How to put it in this course? We should not be very rigid about Wilkins. It is said that more than 8, it's not very favorable, but it's not like that. It is 7, the BMV is going to be very successful, and if it is 9, then BMV will not be done. So it is a spectrum. We have to take it like that. So all the scores have their own limitations. Wilkins is the most commonly used. And this basically is just to convey what type of valve you are thinking, and what challenges the interventionist or the person who is doing the BMB can happen. So it's a universal language. If you say Wilkin 8, then he will understand, okay, it is a borderline valve. It is only for that. Anything extra which we find in the study, we should mention it differently. Like suppose Wilkin is 6, but the subvalvular apparatus is very bad. So it has to be written. If Wilkin is 6, but the commissural calcification is there, so you mention it in a separate way, because Wilkin doesn't takes care of the commissures. There is no mention there. So in Wilkin score, mobility of the valve, thickening, calcification, and subvalvular thickening. Each component gets 1 point, and there are 4 points. So lowest score is 4 and highest is 16. So highly mobile valve with only leaflet tips involvement is 1. And as we go forward, no or minimal forward movement, that valve is not at all opening, that will be 4. For thickening also, normal thickening of 4 to 5 mm is 1. More than 10 mm, if the valves are very thick, so it becomes like the score is 4. Calcification, very small single area, 1. If the whole valve and apparatus is calcified, that is 4. Subvalvular thickening also, minimal thickening is 1. But if the cordees are very fibrotic, thickened, and are pulling the valve, that becomes 4. So the score ranges from 4 to 16, somewhere around 8. If it is more than 8, then the valve seems to be less suitable or suboptimal, what is called. Cormier score is also there, which discusses, just divides it in group 1, group 2, group 3. Group 1 is pliable, non-calcified valve. Group 2 is the valve is good, but the subvalvular apparatus is not so good. And group 3 is the valve is calcified. Same with the News score. This is a better score to predict the success of BMV and the development of mitral regurgitation, and it takes account of the commissures as well. So that it depends on the institute, depends on your team, that which score you are using. But yes, it is better to write independently about the components rather than relying on only score. So what we have seen, just some practical examples. So this is a fibrotic MS. The Wilkins score will be very low because the valve is pliable, moving nicely, and the commissures are free, as we can see here. The commissures have to be labeled. This is medial commissure, this is lateral commissure. The anterior mitral leaflet, posterior mitral leaflet. So there is definitely a stenosis, but there is no calcification. Subvalvular apparatus also seems to be fine, no mitral regurgitation. So this valve seems to be very good for BMB. On the other spectrum, this will be a very calcified mitral stenosis. The valves are calcified. Here we can see that the calcification is also extending to the commissures. So definitely this valve is not suitable for BMB. Then sometimes this is a subvalvular apparatus where we can say the valve is not so bad, but the subvalvular apparatus is very much fused, and cordees are thickened and short, very short in length. So in these patients also BMV can be tricky, because the balloon which we are using for dilatation can get entrapped in the subvalvular apparatus. So it's not like that is contraindicated, but yes, should be definitely be done cautiously in these patients. Then associated tricuspid valve disease has to be looked for, because like in this patient, there is a thickening of tricuspid leaflet. There is a restricted motion here, as well as tricuspid stenosis, maybe mild to moderate TS and severe TR. So associated tricuspid valve disease should be noted. It's not like that it is always contraindicated, but yes, a severe disease will be a contraindication for balloon mitral valvotomy. Any severe valvular disease associated with the mitral valve disease will become a contraindication. So tricuspid stenosis has to be looked for. Many times we miss it because tricuspid regurgitation is always there with mitral stenosis, but whether it is organic, whether it is a tricuspid stenosis involved, that should also be looked for. So with this background, I'll come to a case. This is a 40-year-old male with reported as moderate MS and moderate AS. The patient was quite symptomatic, very dyspneic, on dyspnea on exertion was there. And when we did the echo, we see that mitral gradient was 7.7. PHT was also was not coming for severe mitral stenosis. The aortic valve mean gradient was 24. So what is happening here? So we further did the study, completed the study, and now we can see here that when we took AVA by continuity with we have taken the aortic valve area in the first image, we can see that it is coming to be a severe aortic stenosis. When we check by planimetry, the mitral valve area is also in the severe range. And fortunately, we were able to get a good window for planimetry of aortic valve in the same patient. And this is also correlating with the aortic valve area by continuity. This is 1 and this is 1.1. So both lesions are severe, but we are not getting the gradients. So it's always, we have to be very careful in multivalvular disease because the gradients can be very misleading. And these patients, if we are denying the intervention, that may, it's not good for them. Why it happens? Aortic stenosis assessment, low flow, low gradient AS may occur because of the reduced forward flow. If there is a mitral stenosis, the flow is reduced and it will underestimate the AS severity. Same happens with mitral stenosis. The PHT becomes unreliable because the LVDP is high and the pressure equalization between the LA-LV becomes too soon and it underestimates the mitral stenosis. So low flow, low gradient MS also occurs with it. So it has to be taken care of. Always rely on planimetry. Keep a very low threshold for transesophageal and AVA by continuity for aortic valve, definitely. So this is a paper which discusses about this relatively new entity, relatively new concept, low gradient severe mitral stenosis. And we'll not go into detail, but causes like, if there is an associated lesion, there is a diastolic dysfunction, the patient is elderly, there is an underlying diastolic dysfunction, atrial fibrillation, bradycardia, or ejection fraction is low, LV, RV, both. These causes have to be carefully ruled out. Then surprises we have to be very careful before sending a patient for any intervention, even if you're sending a patient for PMC, BMV. So in the first picture, we see that the MR seems to be like there is no MR. But as we just change the window, we can see that it is almost a low moderate kind of MR. So these patients will, as it's not like that BMV cannot be done, but yes, it has to be documented. The mitral regurgitation is more as what it seems in the first window. Then the clot has to be ruled out. This is a patient who had some mild grade fever, not diagnosed, but he had an aortic valve vegetation, who was scheduled for BMV. So these have to be looked for. So coming on to contraindication, mitral valve area more than 1.5 centimeters square, any thrombus in LA, more than mild MR, severe or bicommissural calcification, absence of commissural fusion, because that is where that is the pathology. So if there is no fusion, then the BMV will not work. Severe concomitant AV disease or severe combined tricuspid stenosis or regurgitation, or coronary artery disease, which is already requiring bypass surgery. In that case, BMV should not be done. Atrial fibrillation in MS, little tricky. The gradients may be misleading. There is a lot of beat to beat variation. If it is a very fast ventricular rate, always try to repeat the study. And the gradients has to be taken as 5-cycle average. Report the gradients with heart rate. And just I wanted to show this, that there has been lot of discussion about whether newer DOACs can be given for stroke prevention in these patients. So these guidelines are very clear about it, that if the mitral valve area is less than 2 centimeters square, we cannot give DOACs. And these patients have to be kept on warfarin or VKS. So this is just a quick revision of the same. We'll not go again into detail. It just simply says that symptomatic patient, intervention required, valve is suitable, do BMV, not suitable, surgery. If the patient is asymptomatic, look for the associated features: high thromboembolic risk, high risk of hemodynamic decompensation. High risk of hemodynamic decompensation means that if the patient is going for a major surgery, if the patient is trying to get pregnant, these patients will decompensate even if she is asymptomatic at this point of time, but they will decompensate when the body is under that stress. So these patients also can need intervention, class 2A recommendation. Degenerative mitral stenosis, annular calcification, there is absence of commissural fusion. Now, as the longevity is increasing, we are dealing with these patients as well. But here, BMV is also not an option, as well as surgery is also very high risk in most of these cases. And usually, they are declined of any intervention. But if the patient is very sick and needs to be intervened, then there are newer options of transcatheter mitral valve implantation in symptomatic patients who have an extensive MAC. There, this valve can be put through percutaneously, like as in TOWER. So that indication is class 2B in the newer guidelines. So that ends up the mitral stenosis. I'll go on to mitral regurgitation, where we have to look at the valve, the ventricle, and the atria now as well. So mitral valve regurgitation has been classically classified as a Carpenter classification, which this classification is very good for understanding the etiology, for understanding the mechanisms behind the mitral regurgitations. Like type 1, the valve motion is normal. Valve motion is normal, but if the annulus is stretched, the valve is not opening, there is a non-coaptation, and mitral regurgitation is there. Or if the leaflet is perforated, it is moving nicely, but there is a perforation or there is a vegetation which is hindering the movement. So there is valve motion is normal. So that is type 1. So as in this case, annulus is dilated and there is regurgitation, but valve is moving normally. Here there is a vegetation. Then type 2 is excessive motion, which we see in prolapse or flail leaflets. As we can see here, this leaflet is flail and it is going into LA. There is an excessive motion. It is moving beyond its line of closure. So that is causing an eccentric mitral regurgitation. Type 3 is restricted motion. Restricted motion can be due to either the leaflets are thickened, like in rheumatic heart disease, or there is pulling of the leaflets, which we'll be discussing more, ventricular secondary MR. The leaflets are restricted because they are being pulled by the left ventricle distortion. So these are the secondary MR. So that is type 3. So this classification, though very interesting, but when it comes to management, we have to classify them as primary MR and secondary MR because that is how the guidelines, how the management is going to go. So primary MR is somewhere where when valve is the culprit, when there is disease of the valve, not of the whole apparatus. The other parts of the apparatus is okay, but valve is the culprit. So first is obviously rheumatic heart disease, severe mitral regurgitation, valve is thickened, subvalvular apparatus is thickened, restricted opening as well as regurgitation. In second example, prolapse or flail, which we saw. So as we can see in this picture, there's prolapse. We will call it prolapse when the tips are towards the LV and it is not going into LA. So that will be prolapse. Excessive motion part of the leaflet is prolapsing, but the tip of the leaflets are always facing towards left ventricle. Whereas in flail, there is a rupture of a chordae, the leaflet goes into the LA during systole. So that is how we differentiate. This picture is for prolapse. And here we can see, if we look closely, that this part is going into the left atrium. And from there, an eccentric severe mitral regurgitation is coming. So this is important to understand for both cases. If we can see if we see a flail leaflet, most of the times the regurgitation is going to be severe, and it may be eccentric. So looking at the flail leaflet, we have to do transesophageal if possible. So that's how we see prolapse or flail. Then here also we can see a flail leaflet. This patient was diagnosed as rheumatic heart disease, moderate AR, severe MR. But when we looked closely, actually it was a bicuspid aortic valve, and from where moderate aortic regurgitation was there, and maybe because of the persistent turbulence and it was hitting on the chordae, there was a chordae rupture, and which ultimately resulted into the severe mitral regurgitation. So it was not a rheumatic disease. As you can see, the leaflets are very thin. So this kind of etiology was also very important, understanding the so large area of mitral regurgitation is happening here, that the leaflet is flail. Acute MR, when there is a chordae rupture due to ischemia, due to infective endocarditis. If you look closely, there is a chordae rupture there, and severe MR is there. So these are all kinds of primary mitral regurgitation. This is a busy slide. We'll just look at the first half of the slide, that, okay, we have to ensure that echocardiographic criteria for severe MR is fulfilled, as I have shown: flail leaflet, large defects, severe tinting, large central jets, large flow convergence zone, and semi-quantitative. Clearly, we are seeing that the vena contracta is more than 6, 7. Pulmonary vein systolic flow reversal is there. E waves are very, more than 1.2 meter per second. Quantitative, if you're able to do PISA, very good. But in most of the cases, we will be able to make a decision by qualitative and semi-quantitative methods if you look closely. So that is how we categorize that, okay, this is a severe MR. Then comes to the mechanism. Primary MR, I have shown the examples. Secondary MR will be discussing in the further slides. Criteria for intervention, I'll show in the coming slides. So severe primary mitral regurgitation, patient is symptomatic and is not a high surgical risk, he needs to go for mitral valve surgery. So symptomatic severe primary MR, not a high risk surgery. If he is at a high risk, then percutaneous option of TEER, which is transcatheter edge-to-edge repair. If the patient is asymptomatic, again, then we have to look very closely what we were doing in mitral stenosis. First is LVEF less than 60, ejection fraction is less than 60, or LV is dilated more than 40 mm of end systolic dimension. Now they have also included newer in the guidelines because our Indians body surface area is different. We have to is lower than the people in the West. So we should always take an index dimension, indexed volumes. So remember 20, 40, 60. If the left ventricular end systolic dimension indexed is more than 20, ancestral dimension is more than 40 and ejection fraction is less than 60, these patients also need to go for mitral valve surgery, even if asymptomatic, and that is class 1. But here it is a catch that repair is preferable. So class 1 is repair. If repair is not there, then class 2A. If it's not there, the LV is not dilated, ejection fraction is normal, then also if any of these three is present, patient is in AF, pulmonary arterial systolic pressure is more than 50, or the left atrial volume indexed is more than 60, or if the LA diameter is more than 55, the TR is more than moderate, then also any three of these is present, again, intervention. If no, even if atrial fibrillation is there, pulmonary arterial systolic pressures are more than 50, if patient can undergo repair, he should be sent for, because usually these primary MR patients may be young. And if we wait for them to develop symptoms, the LA will get huge, they will develop atrial fibrillation, irreversible kind of damage, and the results will not be so good. So these patients should also be sent for surgery, given an option for surgery. If nothing is there, then watchful waiting. So this is a quiz. I'll just take a minute to show who are the participants. They can see this clip and just comment in the chat box, or they can just write it down and later on we'll discuss it. So what is the severity of MR in this case? Is it mild, is it moderate, or is it severe? So now I'll move on. As I discussed, same slide, just a revision. These are the newer guidelines. Always look for this and report it also in the your echocardiography report. End systolic dimension, indexed dimensions, ejection fraction, then at rest, atrial fibrillation. If it is there, we should mention it. Okay, atrial fibrillation, this heart rate. If it isn't mentioned in the echo report, then when this kind of report goes to the surgeon or the clinician, then it gets very easy to make an informed decision. So it is the same revised recommendations. Why this happened, from where these determinants have come, because there was a study done. This is the study from where these parameters have come, that we have to see the left atrial volume index, we have to see pulmonary systolic pressure, because it was seen that if all the four were present, three or four of these determinants were present, then the patient didn't fare well. The survival probability decreased dramatically because intervention was not done. So from this study, it has come to that if any three of these secondary outcome determinants are present, then definitely we should offer surgical intervention. GLS can also be used for these patients, and the cutoff for GLS is a little higher because it's a hyperdynamic ventricle. So cutoff in this study was taken to be -20, and it was seen that if we intervene when the GLS starts decreasing, even in asymptomatic patients, it gives a better outcome. Coming on to secondary mitral regurgitation, where valve is not the problem. It is actually the other
Shraddha, I
parts of the
think,
apparatus. Hanji
Shraddha, I'm
ma'am?
just sorry, I'm interrupting. I think
Yes,
for
ma'am.
today, we hold it till primary MR. All right.
Whatever
And
you say,
because,
ma'am.
yeah, because it is already 45 minutes. So we will, touch upon the TDI also partly. And
Sure, ma'am.
in the next session, because secondary TR will be important in the sense that you will be talking more about TR and the
Yeah.
indications and post-ear echo and all those things, which would be a kind of, almost a separate entity.
Yeah, sure,
Okay,
ma'am.
so we
Got
will
it.
do that in the next session. But so it was wonderful. And anyone has any queries, you can put it in your chat box and we will answer that. And before we move on, let's see how much have you learned. We will have a quick revision. Shraddha, you have unshared, na?
Yes, ma'am.
Okay, let me share. Let me share.
Ma'am, till now there is no question as such.
No question? Good. So they have understood it all. Right. Great audience.
It was a very beautifully illustrated presentation. It was
Yes.
nicely explained. Yes.
Yes,
Thank you, sir.
indeed. Indeed. That was great if people have heard about it, because see, it is not just doing echo, it is also about, you know, how we interpret it and what not to be missed while
Yes.
we are doing echo. है ना?
It
Okay,
was
so
a very clinically useful lecture and clinical useful approach.
correct, correct. So, so I have taken some important things from Shraddha's talk, and I have just tried to, can you see my PPT?
Yes, ma'am.
है ना?
We can
So,
see it. Huh?
हाँ. So it is little random, but then I didn't get time actually to organize it also. But I think if we will just go through them, we will just go through them and then have some questions. All right. So operate before the ventricles fail. So why was she saying that, these numbers, why are they important? 60, 40, 20. It is because, we don't want them to fail to an extent that beyond which even the repair will not be successful. Right. Dr. Manish,
Yes,
I think you should be commenting, with these kind of things, what I'm telling, because why they are important is also something they should understand.
that's true.
Right.
Uh,
So I think you should
yeah,
explain the audience and you tell about your own, some suggestions on this talk first.
no, it was a very good overview of echo assessment and decision making in MS and primary MR. So as you're showing here, basically the idea is that we want to intervene in these patients. Uh, I'm talking about MR here because the slide talks about MR. Is that you see, when patient undergoes the surgery and ends up receiving prosthetic valve, then the prosthetic valve also comes with its own morbidity and mortality risk. So we have to balance. We have to offer surgery at a time when the risk of doing surgery is less than the risk associated with delaying surgery. So here, EF less than 60%, there's a lot of data which shows that if EF is less than 60%, then these patients are more likely to develop further fall in EF and their prognosis is worse. LV and systolic diameter more than 40. So this is again a measure of LV systolic function, not LV dilatation, which I would like to clarify to everyone. In MR, as the LV volume increases, LV contracts more, so it ultimately end up ejecting more blood. So LV end systolic dimension remains normal. When LV end systolic dimension touches 40 millimeter, goes beyond that, then it means that LV is failing. So it is a measure of LV systolic function dysfunction. Then new AF, elevated PA pressure, and moderate functional TR, all these indicate that the load caused by MR is significant enough to warrant surgery. And in all these patients, if we can do mitral valve repair, then the thresholds are lower because with repair, the long-term morbidity of prosthetic valve is not there. But if the patient has to undergo surgery with mechanical valve or even tissue valve, then the thresholds for surgery or for intervention are a little higher because of the reason that I just mentioned.
Yeah, so thank you, Dr. Manish. I have a question on behalf of the audience.
Yeah.
Which parameter is more effective, the EF or the LV end systolic dimension?
Both are important. LV and systolic dimension is just one unidimensional parameter. So we know that uh, the one single parameter may not be accurate enough. But
Yeah.
there's a lot of data with LV and systolic dimension because older studies use this. This was easier to measure and more reproducible than EF.
Yeah. That's what I was coming to. That it once it happens, it is a indication of failing, meaning dysfunction
Ventricle.
of the ventricle,
Yes.
right? And EF can be the interpretation may be very varied
Yeah. And
due to.
actually, this also highlights why we need to be objectively assessing EF.
Uh,
Because in a patient with severe MR, LVF 55% is LV systolic dysfunction.
Correct.
We tend to write normal LV, no wall motion abnormality, EF 55%. So we have to be careful about that. We should be using proper techniques like Simpson's method, or if available, then 3D for estimation of EF and report accurately. GLS is another parameter which has shown a lot of utility. In
So
case of
is it documented, Dr. Manish? Because that's what I was coming to, that apart from EF, early dysfunction with the help of GLS or TDI, is it going to be more helpful?
so with EF with GLS again, there is a large study from Mayo Clinic which showed that in patients whom LV GLS was more than 19%, more than meaning more negative than 19%, in them the outcome of patients who underwent surgery versus conservative management was same. But when GLS was less than 19%,
Hmm.
then patients who were treated medically, they had much worse outcome.
Oh.
And based on this, one group of investigators has actually recommended LVGLS as one of the criterion for deciding about surgery. But guidelines do not
Still
incorporate it because
recommend.
we don't have randomized data to support this recommendation. But
Hmm.
GLS is important. We should be properly measuring it, and especially in a patient who's coming for regular follow-up, if we see that GLS is falling, then
Hmm.
we should be more alert.
Hmm. Hmm. And also, as seen here, wherever the pulmonary artery pressures or the functional TR is in a significant amount, which means that the LV is failing already.
Yeah, there is significant back pressure effect
Back
because
pressure,
of M.
yes. So, all right. So these things are to be remembered, that they should trigger our judgment towards doing something for the mitral valve, for the repair or the surgery. And as
Yeah.
Dr. Manish said, repair would always be preferred because of its lesser morbidity as compared to the
In
prosthetic
in
valves.
younger patients, but in older patients, 60, 65, it
Hmm.
repairs in Western countries, they will still do repair at 60, 65 because that is a young age for them, not that
Hmm.
old.
Hmm.
But in India, I think 60, 65 is an age where if the surgeon is not confident in repair, then better to
Hmm.
go for a good tissue valve, which has a
Hmm.
longer durability,
Hmm.
than getting repair done and end up
Hmm.
having residual MR. And this valve will not be amenable to any percutaneous intervention also later. So patient will necessarily need second surgery if there is any problem,
Hmm.
which may not be a case if patient receives a tissue valve. He or she can then later undergo TMVR. So in younger patients, definitely repair is much better, but in older patients, both may be of same long-term outcome.
All right. All right. Thank you. So we move on to the second thing. So I have just made a question, I think that will help you understand the concept. A 40-year-old male, a case of RHTMS with mitral valve area 1.5 centimeter square, is in atrial fibrillation. Which anticoagulant will you prefer to give this patient? The BKAs, which is acetrom and warfarin, which we use regularly, the DOACs, the any of the above is okay, and I'm confused. So what is the audience for? And this is this is based on what Shraddha has shown in her talk about the anticoagulants, and is important to understand. Dr. Rohit, any answers? Manish, can you see any questions or answers? Sorry,
VK,
VK. Why?
Devarchana Sarkar has recommended VK.
Okay. Guys, you all should be participating, na? Doesn't matter. At least the concepts will be cleared. Dr. Manish, now can you elaborate on that?
Yeah. So you see, in mitral stenosis, rheumatic mitral stenosis, there is left atrial remodeling plus left atrial inflammation also, and other pathologies which are happening, because of which thromboembolic risk is much higher than that can be managed with these DOACs. Warfarin remains the most effective agent. The problem with warfarin or acetrom is that it's difficult to manage anticoagulation level. Otherwise, it is the most effective agent. So conditions where the risk is very high, like metallic PHVs or rheumatic MS or Epla syndrome, these are the three conditions in which we will use vitamin K antagonist, because DOACs are not effective enough to prevent anticoagulation in these patients. But I will make one uh, okay, important point here, that if the same patient undergoes surgery and has received a tissue valve and continues to have AF, now we can use DOAC.
Okay, why is that so?
So because in the in this trial with Epixab and Aristotle trial, there were many patients, good number of patients who had undergone mitral valve rheumatic MS, because it
Hmm.
was conducted in Brazil also. Rheumatic MS post MVR, and it was found to be equally effective. The reason is that once mitral valve replacement has been done, then it reduces load on the LA. Stasis of blood becomes less severe. So the chances of clot formation go down, and that's why now Epixaben is good enough for managing
Even for
embolism
the
risk in this.
post BMV patients as well, sir. Even for the younger patients
Uh,
after BMV, they have mild MS. We can use NOACs now, no?
so for mild MS, mild rheumatic MS, NOACs are okay, but moderate to severe, they are not okay. Tissue
All right.
valve, regardless of the underlying etiology, DOACs are okay.
Right. I have a question. Suppose, we have very big LAs. Okay. Even before, like, before surgery, we have a LA of say 4.5, 5.5. All right. We have done a surgery. The LA will not decompress as early. It will take
Yes.
its own time and may not completely regress also. And this
Yes.
usually stay like this. What about in those situations? What should be the preferred thing? Because the pathology is still there, the rheumatic pathology is still there. It is quite dilated, wherein stasis is quite possible. What should be the stand in such patients?
So actually, guidelines don't make these very specific recommendations. The latest guidelines give a broad recommendation that in a patient who's got tissue valve, you can use
Hmm.
DOAC. So it
And maybe
depends on
that
the,
such patients must be in AF also.
yeah,
So
only when there is AF. If AF is not there, then
uh,
we will use aspirin.
ha. Hmm. All right. All right. So good. I think this must have clarified the confusion about the anticoagulants. Not confusion, in fact, more clarity on where to use what. That's important because with DOACs, the monitoring is very minimal and can be very safely given.
Yes.
Yeah. Okay. So the next question is, you're doing echo on a 32-year-old female with the shortness of breath class 3, and you find the presence of severe MS. What would you like to see next in the patient to decide treatment strategy? Associated MR, commissural status, meaning presence of fibrosis or calcification, subvalvular apparatus, LA or LA appendage clot, all of the above. This is simple.
Yes. A lot of replies, ma'am. Everybody is giving
Must
a
be
correct
right.
answer. Yes,
Ha.
yes.
That must be right. Yeah. Dr. Manish,
Yeah.
so just clarify A, B, and C. D is quite evident. Why associated MR is important to know, once we are deciding in BMV.
So you see, if MR is significant, then BMV can lead to worsening of MR. That's the reason. But here, before I answer your question, I would like to add one more point. I would definitely like to know the marital status of the patient and the whether she has completed family or
Okay.
not.
Hmm.
Suppose she has to have a baby,
Hmm.
then I will be very much again would like to avoid mitral valve surgery and give her a metallic valve. So if there is mild MR or 2x4 MR, I think it is worth taking a chance because even if MR increases, she will be able to tolerate that MR during pregnancy compared to what MS will be producing hemodynamic load. So all these becomes except for LA appendage clot, others will become relative contraindications if pregnancy is contemplated.
Right.
So that will also change. Commissural fusion, Shraddha mentioned very clearly
Yeah.
that if the commissure is calcified and then we inflate the balloon, we will not be able to split the commissure. Leaflet will get torn. So calcification in the commissure is a definite contraindication to significant calcification in the commissure to BMV. Conversely, if commissures are not fused, then again BMV will not help, as we see in patients who have got degenerative MS or MS because of connective tissue disease. So only when ideal situation is that both commissures are fused, not densely fibrosed, not calcified. That is the scenario in which we get the best outcome from BMV. If one
Yeah,
commissure
because
is fused,
the
yeah,
mechanism of BMV is to stretch,
to split the commissure.
split the commissure.
Yeah, we don't want to split the leaflets. We want to
Yeah.
split the commissure. So if
Hmm.
one commissure is fused and other is open, again BMV will not work because the moment we inflate the balloon will be pushed towards the open commissure.
Hmm.
So both
So ideally,
commissures
both the
fused.
commissure should be fused.
Yeah, that is the best scenario,
Hmm.
but not calcified.
Yeah. All right. Yes. And
And
in MR
subvalvular.
also, if it's mild, that's okay. Anything more than mild, because post BMV,
No,
the
no,
MR.
no, 2x4 MR is also okay.
Hmm.
And in fact, in children, even more than 2x4 is also accepted
Hmm.
instead of subjecting them to surgery because they will receive metallic valve at that young age.
Yeah.
So MR is not that big a contraindication.
Hmm.
And in fact, many times MR decreases after BMV
Hmm.
because once BMV is done, the leaflet mobility becomes better
Hmm.
because commissure fusion has decreased or
Bec-
gone.
uh,
So MR may decrease also, not
hmm.
necessarily increase.
Hmm. Hmm. Great. Great. And anything to comment on the subvalvular apparatus? Because as Shraddha has mentioned, that if the cordia are very short, fused, and the entire subvalvular apparatus is quite fibrotic, then it may be a challenge for the BMV operator.
That is also true, and at the same time, BMV itself will not give the desired benefit because obstruction is at another level.
Hmm.
So you open the valve, but there is fusion of the subvalvular apparatus. So
Hmm.
patient will continue to have significant MS.
Hmm.
So BMV will not work that well.
Hmm. Hmm. And so I think this is one of the situations wherein there is a discrepancy between the planimetered mitral valve
Yes.
and
Yeah.
the gradients that are obtained,
Gradient. Gradient. Yes.
right? Because we are
Yes.
getting high gradients, but the valve is not up, the planimetry is not telling us that the valve is severely stenosed,
Correct.
right? So, all right. So in those cases, surgery is a better option because you can't open the valve and the gradients will stay high.
Yes.
All right. So we move on to the next question. All are features of a good BMV candidate except, very easy. Just these are all to just to revise, and when we put it in a clinical situation, what is there, it is just to brush up. So I think everybody must be clear about it. The answer is D. So this I'm moving. Okay, BMV is contraindicated in all except. Dr. Manish, your comments. Any answers in the chat box, Shraddha?
Everyone, almost everyone has answered A. No, some have
Huh.
answered D also.
Huh.
Oh, they have not understood the except word. That's why.
Oh, this is except.
They-
I,
Mhm.
this is a typo error. Wow. Shraddha, you pointed it out. I told you I made it in a
No,
All
big.
not about
X.
the spelling. Not
Yeah.
about the spelling. They have just looked at ki contraindicated. So
Yeah.
that's why they have answered D. So
Ha
it
ha.
is,
So
but
Dr.
most of them
Manish,
Answer
have
is A,
answered correctly.
yeah.
correctly.
Can you please
So,
explain this? Yeah.
no, we have already discussed this.
Ha ha. But just to revise.
Because if there is LA thrombus, again, you see, if there is LA thrombus will be big. If LA appendage thrombus is there and we don't want to do surgery, we may give anticoagulation, wait for some time, and then repeat T. But by and large, LA thrombus will be a contraindication because of risk of embolism, heavily calcified AML. Even if we do BMV, it's not going to help the patient. Severe MR, we do BMV, MR is likely to worsen, so no point. And MR will not be taken care of. Fused medial commission is the only scenario where it may be, it will definitely be tried. But if both commissions are fused, as we discussed, then even better.
Yes. And as you said, both are better. So that's how. Right.
Both partially fused.
Yeah. So the next question, asymptomatic severe MS with pulmonary hypertension more than 50 mmHg, what is the right management? This again has been picked from the talk and from the guidelines. Patient is asymptomatic, remember, but there's something, which is there in the question as per the guidelines, which can, motivate you for some decision making. Have they answered?
No, I don't know whether the answers are for this question or the previous. Okay, now there is a barrage of C's here. That
Ha,
means they are now answering to
ha,
this question.
correct,
Okay.
correct. Any comments, Dr. Manish, or we move? Because
So
this is a,
here, I would definitely want to be sure that the patient is truly asymptomatic. I would
hmm,
do stress echo in this patient
hmm,
to assess
hmm,
symptomatic status.
hmm,
And I'm sure the patient will have compromise of functional capacity, which we will be unmasked by doing stress echo. Once documented, then I will definitely like to send the patient for intervention.
hmm,
PMV will be preferred because pulmonary hypertension alone is 2A indication for surgery.
hmm.
But if the valve is not suitable and patient has reduced functional capacity on treadmill, then we will consider surgery also.
Hmm. All right. So yes, he's right. So we can always, whenever we have such kind of scenario, subject your patient for some kind of stress and evaluate again post stress, and see that if you have an increase, as she said, increase in gradients and increase in the pulmonary artery systolic pressures post Shraddha, it was more than 15 millimeters mercury and more than 60 millimeters. Oh,
On
sorry,
exercise, yeah,
yeah, on
15
post
and
exercise, the
16.
PSP, right? PSP more than 60 post
Yes,
exercise, and gradients more than
more than
More than
15.
15.
50.
Yeah. All right. So
Yeah.
just remember these two things, because this we can, very well apply in our clinical practice.
Yes.
All right. So what does primary MR refers to abnormality of? Very simple. Just to understand that the concept of primary and secondary MR, where is the pathology? I have kept this question. Very easy, mitral valve apparatus. She has very well explained. So remember
Yeah,
any
lot of
disability.
B.
Yeah, lot of B. Chalo, good,
Yeah.
good. At least they have heard it.
Yeah.
Okay, most common cause of primary MR. In our country, it is RHT. In Western countries, it is mitral valve prolapse. Then, the answer is all of the above, actually. These are the common causes we come across. Any comment, Dr. Manish?
No,
ठीक है.
as you mentioned.
Yeah, yeah. Which of the following is not a cause of primary MR? Again, now this is, I'm holding my nose from my hand wrapped around my head. So understand what is primary MR. This is the pathology of the mitral valve apparatus. So something is there where the mitral valve apparatus is not involved. The pathology is different and it is called a secondary MR. It is dilated cardiomyopathy. Okay. So all are the indicators for early surgery in asymptomatic severe MR. Because see, whenever the patient is symptomatic, the problem is over. But when the patient is asymptomatic, then the decision becomes a little more critical and we need to be then working on all the numbers. So here the accept spelling is correct and we have to identify that which is not an indicator, right? So tell me if you could guess that.
Hmm. I think there are two answers here.
What?
So waiting for them to answer first.
Yeah. Try. Nobody is judging you here. Try your knowledge. Try, and then improve your. Once the please mute yourself. Delegates, please mute yourself. I think more answers are coming up.
Yeah. AE.
A and E.
Both are correct.
No, but anything more than moderate functional MR should be considered.
No, so actually, in case of functional MR,
Hmm.
there is no indication.
No, but
Functional
this.
MR, so functional MR is because of LV dilatation and dysfunction, usually. If we are talking of ventricular secondary MR, not
Oh,
the
so
atrial
so
one.
so so again there is a typo error. Sorry, this is a typo error. This is TR, moderate
Okay.
functional TR. I'm
Hmm.
sorry.
Yeah.
This is a TR because MR is anyway severe. So we are working on a
Sorry.
case of severe MR, and in
Hmm.
that we have a TR which is more than moderate,
Yeah.
meaning high back pressure, na?
So actually, more important than TR severity is the size of the tricuspid annulus.
Hmm.
If tricuspid annulus is dilated,
Hmm.
then even if TR is just 2 by 4 or mild,
Hmm.
guidelines do recommend intervention on tricuspid valve at the same time
Hmm.
when patient is having mitral valve surgery. If
Oh.
the annulus is dilated, the
Hmm.
reason is that once tricuspid annulus becomes dilated, then it does not regress. Many
Hmm.
studies have shown.
Hmm.
So in these patients, TR keeps on increasing gradually, even in MS. So initially, TR may decrease because of the reduction in pulmonary pressure, but because tricuspid annulus has become dilated, so gradually TR will keep on increasing. And that's why we see so many patients coming back to us with severe TR who undergone mitral valve replacement many years ago.
True.
So
This is a bad situation.
tricuspid annular dilatation is an indication for tricuspid valve intervention regardless of TR severity. The
All
next
right.
question then is what do you mean by tricuspid annular dilatation?
Hmm.
So it is more than 21 millimeter per meter square annulus size. For Indians, it will come out to be around to 3.5 centimeter absolute value.
Hmm. Otherwise, it is 4.
4 centimeter.
Yeah.
That was from the Western data,
Correct.
but the current guidelines recommend 21 millimeter per meter square or more.
Hmm. 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 All right. Good. So I think here A fits in because the
Yeah.
ejection fraction is good, still good, and the LV has not yet dilated more than 40. So 60, 40,
No,
20.
again,
हाँ,
this is not a
tell me.
measure of LV dilatation,
हाँ. No, LV dysfunction. I
LV
mean LV
dysfunction.
dysfunction. Correct, correct, correct.
Yeah.
Yeah, I correct myself. It is a measure of LV dysfunction eventually because
Yeah.
chronic overload leading to, finally LV dysfunction, right?
LV diastolic diameter is a measure of LV dilatation in MR.
Hmm.
LV systolic dimension is measure of systolic function, not dilatation.
Perfect. Perfect. Right. I correct. So we move on. Anna, we have discussed enough in this. All right.
Yeah.
So I think,
So just one comment I would like to make. So as
yeah.
Shraddha mentioned in her presentation in the beginning itself,
Hmm.
that when we are doing echo, our goal is not to just provide numbers, but to help
Yes.
patient management and decision making.
Right.
That's something very important that we need to remember. When we start doing echo, initially our whole objective is to get the findings correctly. But then as we mature, we realize how important it is to provide other information which will make help the treating clinician make a decision. For example, if the patient has got severe AS and I am called to see echo, the fellow is doing and he or she is calling me, and then if he or she tells me कि सर सिवियर एएस है, मेरे को एआर भी दिख रहा है, मॉडरेट है, मुझे पता नहीं लग रहा है कि कितना है, मेरा आंसर होता है कि एआर कितना भी हो डजंट मैटर, टेल मी अबाउट अदर वेल्व्स, टेल मी अबाउट वॉल मोशन, बिकॉज एएस तो है सिवियर, patient will undergo AVR. Similarly, if severe MS is there and patient is admitted for AVR, I ask about other valves. PR का क्या situation है, annulus क्या size है, because those are the decisions, those are the things which will help decide when to intervene, how to intervene. And for AS, I will be more interested in knowing the annulus size than exact severity of AS. If it is severe and patient is undergoing surgery, it doesn't matter whether the gradient is 70 or 60 or 80. So all these other additional information which will help you decide about the patient management, they are very important to provide.
Right. Most of the times, what happens is that doing echocardiography, we become very passive.
Hmm.
We are just, recording the numbers and sending the patient off. But the one who has to take the decision
Yes.
is in a great confusion.
Yeah. So a patient with severe MS also has moderate AR. Now the question is whether to send the patient for BMV or DVR. DVR is a big ask. So if the valve is not very suitable for BMV, I might still be inclined to send the patient for BMV and wait for a few more years by the time AR will also progress and then send the patient for DVR. So
Yes.
we have to think from the clinician's perspective when we are doing echo. Then our reports will become very impressive and will actually make the difference that we want to create.
Yeah, that is why, this topic was so interesting. I just thought that, while we are practicing echocardiography, we should be really alert with open mind here, all standing, thinking that, yes, this is possible and I should not be missing it. Right. So that was the idea because when Shraddha, discussed about this talk, I said, yes, let's make it with discussions, because yes, guidelines important. She discussed everything, but probably, when we discuss, things go more into our head and our mistakes are clear. So many
Definitely.
things you have just said, which have hit me also and probably will stay for some time. Right? But now the thing is that it is 9:10. So I think Ranjan,
And 10.
yeah. And I think Ranjan, is it okay if we do it next time? Because it will be too
Definitely,
exhausting.
definitely,
है ना? And
definitely.
because TDI again, when I was going through your presentation, it was too good. And I think there is lot to discuss.
Yeah.
And Dr. Manish, one more request. So next time when we have whatever is your convenience, We will do the session accordingly because this TDI is very important, right? So
Sure.
I have again, 100 questions to be asked.
Definitely.
Okay.
No,
Yeah.
no, it will be more than a pleasure for me also to join and participate in the discussion.
Yes. Shraddha, you were saying something?
You don't lose an opportunity. That's what I was saying.
Yes, yes, yes. It is for, in fact, all of us.
Yes.
We are not perfect. Our learning curves should be always going up. And whenever given an opportunity, people like Manish, when they are here, I think, we should gain the maximum out of all of them.
It's
Right.
actually it's learning for everyone, for me also, because the questions many times we don't even think of those questions that one can ask, and then the question is asked, then you also start thinking कि अरे ये पूछा है पहले तो सोचा ही नहीं था कभी.
So,
So what
China,
should be the answer? So
correct.
yeah, those things happen.
Yeah. So I was going through Ranjan's TDI, this thing. So why E upon E prime? Why not E prime upon E? What, came like this, yeah, how this concept of E upon E prime came, and it correlated with the LA pressures. So that was actually very interesting. So Ranjan, I would like that, we discuss it properly as a prime talk, because
Okay.
now if we start it, it will be kind of exhausting, and it will not make sense. So I
Definitely.
think, next time we will take it as an entire thing, 40 minutes talk, and
And
then we will
then
again
we
make
have a
questions and discussions.
discussion.
है ना?
There will be a
Because
lot
all
of
of us,
discussion.
yeah, all of us come across a lot of problems. So all the participants who are here right now, just keep doing TDIs, take out your questions, take out your problems, that this is what you face. Because I keep asking Dr. Manish a lot of times, respiratory variations, this, that. So keep your questions, and in May, let us do the TDI as a full-fledged session,
Definitely.
right?
Okay.
So thank you very much, Dr. Manish, Dr. Shraddha, Ranjan, thank you for being here. Dr. Rohit Tandon, Dr. Rakesh has come or not? I wanted him to be here today, but as usual, he must be busy in the OPD. But thank you everyone, for being here till last. And I'm sure you must have, yeah, matlab, kuch appreciation to diya karo. Everybody must be sending some claps or some, flyers up. Yes, Ranjan, yes, thumbs up, claps, right? At least motivate the speakers. Nobody comes up, right? They are coming
Thank
and
you. Thank you, ma'am.
yeah, they are coming and helping everyone out to learn. So they should be given some extra motivation always. So Shraddha, claps, lots and lots of claps for you. And you
Thank
did
you,
it
ma'am.
very well, instigated us. And this is a very, very nice topic. A very nice topic.
Yeah.
One must really keep it in mind. Thank you,
And
everyone.
as Dr. Hansa mentioned in the beginning regarding conference,
Yes.
she would also like to tell you that abstract submission is open. You can submit your case studies. If not research abstract, if you can submit research abstract, nothing like it, but so many cases you have, it is an excellent opportunity to showcase your work at such a grand forum. So please submit as many case studies as you can. There's no upper limit.
Yes. Very rightly pointed and very timely, Dr. Manish mentioned about it. So good, and come, all of you should participate, learn, and share. All right. So Reena, ending up with the formality, but no, it's deep from my heart the way you take care of all this, backstage work. Thank you so much for
Thank
all
you,
the
ma'am.
help.
Thank you.
Yeah. So thank you all. Manish, thanks once again from the core of my heart
Welcome.
for being here. Thanks, Ranjan. Thanks, Shraddha.
Okay. Good
Thanks,
night.
Dr. Rohit.
Thank you,
Good night,
ma'am.
Good
everyone.
night.
Good night.
Bye.
Good night,
Good night.
ma'am.
Bye.